Good afternoon, everybody. We big greetings from Vijaya Diagnostic Center. A warm welcome to all. I am Dr. Manisha Singh, heading the Department of Microbiology at Vijaya Diagnostic Center, Himayatnagar. After the scorching heat of May and June, there is sudden relief due to showers of rain. This rainy season brings much needed respite from the heat. Along with it, we have another health related challenge, that is plethora of monsoon diseases. To discuss regarding the monsoon diseases, we have with us young energetic consultant microbiologist Dr. Lata B. Galate. She has completed her MD from TNMC and Nair Hospital, Mumbai in 2014. She has completed her DNB from JICMAR in 2015. She has a total experience of 9 years as a consultant microbiologist. She is an active member of Hospital Infection Control and has completed her DIPC and CICP also. She has 10 publications on her name. Now over to Dr. Lata Galati.
Good afternoon, all. Welcome to the educational webinar series from Vijaya Diagnostic Center. I would like to thank Dr. Manisha Singh, madam, for her introduction and kind and inspirational words. So now, as we have entered in the monsoon season, today we will be discussing the diagnostic approaches for monsoon fever. During our discussion, I'll be throwing the light on prevalent monsoon fever, its syndromic approach, basic and specific laboratory investigation also. So, as we all are aware, different parts of India are hit by different seasonal fever, predominantly in the monsoon and post monsoon season. This is because maybe due to high humidity and temperature condition in our country, which favors the growth of vector and different microorganisms. Diagnosis and management of these monsoon fever on time is very important, as if not treated on a time, it may run dramatic course. Diagnosis is also important from epidemiological purpose also. So these are the different monsoon fever diseases today we will be discussing. So topmost is the dengue, malaria, a rickettsial infection caused by vector, leptospira, typhoid fever by bacterial infection and viral infection, diarrheal syndromes, and sepsis and multi-organ dysfunction. So all these monsoon fevers overlap with one another in terms of a symptom, which poses a great challenge for its timely diagnosis. Syndromic approach help the clinician regarding the commonest etiology and investigative modality and help them to choose early empiric therapy. So, this syndromic approach has been divided in five major syndrome for ease of diagnosis and management. First of all, we will look into undifferentiated fever. Here, there will be irregular fever spike with the general symptoms like fever, malaise, myalgia, nausea, vomiting, etc. So, differential diagnosis for these undifferentiated fever are malaria, scrub typhus, leptospira, typhoid, dengue, and other common viral illnesses. Most important and most commonly encountered is fever with a rash and thrombocytopenia. The differential diagnoses are dengue, rickettsial infection and meningococcal infection, malaria, leptospira, measles, and other viral fever. Fever with acute respiratory distress syndrome. The differential diagnosis for this syndromic approach are scrub typhus, falciparum malaria, influenza, specifically H1N1, and leptospirosis. Febrile encephalopathy. The differential diagnosis are scrub typhus, cerebral malaria, typhoid encephalopathy, and encephalitis, which is caused by different virus, specifically HSV, Japanese B, and other viral encephalitis like encephalitis caused by enterovirus group of organisms. Fever with multi-organ disinfection. In this group, this is the group wherein the complication of the all prevalent monsoon fever will be there. So differential diagnosis will be falciparum malaria, leptospirosis, scrub typhus, dengue, and fulminant hepatitis. So, for all these syndromic approach, one can advise very basic investigation, which will help us to differentiate the different etiology. The most important basic investigation one can advise is a complete blood count, wherein one can able to see the different picture of a differential count. If leukocytosis is there, one can suspect leptospirosis, enteric fever in children. Leukocytosis is also seen in enteric fever in adult with the onset of a complication. Leukopenia is specifically seen in a dengue fever, and lymphocytosis will help us to rule out rickettsial and viral infection. Thrombocytopenia is the most common finding in acute febrile illnesses. Coming to the peripheral blood smear examination, most of the vector-borne parasitic infection like malaria, filariasis, trypanosomosis will be diagnosed on blood smear examination. Urine examination will help us to rule out proteinuria, hematuria, and hemoglobinuria, which is seen in leptospirosis and severe malaria respectively. Biochemistry tests like LFT, KFT, which is nothing but a kidney function test, hepatic function test, or liver function test, which help us to rule out involvement of hepatorenal and pulmonary renal system, which indicate us the diagnosis of scrub typhus and leptospirosis. Imaging study are helpful in case of a complication like dengue fever, ARDS syndromes, and perforation in case of a typhoid. So these are the basic investigation when patient approaches to us, one has to advise so as to reach a specific differential diagnosis. First of all, in specific infection, we'll discuss the scrub typhus. This is very less known disease in general population and also underreported because of the diagnostic challenges. This is caused by the Orantia group of microorganism and spread by the vector triggers, which are nothing but a larvae of a trombiculate mite. It is seen mostly across the India, and this organism specifically involve the vascular endothelium, which eventually involve the major organ system of the body, leading to multi-organ dysfunction if not timely diagnosed and treated. Coming to clinical feature, the clinical feature will start with a general symptom like fever, headache, myalgia, breathing difficulty, jaundice, and ischia. Incubation period is generally 1 to 3 weeks. If not diagnosed and treated on time, the patient may land in the ARDS or hepatitis, aseptic meningitis, and disseminated intravascular coagulation. The diagnostic approach for scrub typhus, one can advise these battery of investigation. The most routinely prescribed one is Wellflix agglutination test, which has the sensitivity and specificity of 89%. One can also advise the rapid immunochromatographic test, which has the sensitivity of 96% at max and 99% of specificity at max. The most confirmed and suggested test, scrub typhus IgM enzyme immunoassay, is the advisable test. We have a gold standard test also like PCR, which has the specificity of 100%. So, coming to the interpretation of most commonly advised test for scrub typhus, well-flex reaction. In this test, the antigen used is the protease specimen antigen, as it shares these antigen with Rickettsia species. So, typhus fever and spotted fever, one can see the agglutination with OX19 and OX2 also. But in case of spotted fever, the OX2 is strongly agglutable, and in case of typhus fever, it is variable. In case of scrub typhus, only OXK antigen agglutination is evidence. In Coxiella, that is Coxiella burnetii organism causing Q fever, all antigen will show negative agglutination reaction. Coming to the next prevalent monsoon fever, that is leptospirosis, which is predominantly caused by Leptospira interrogens and spread by direct skin contact of and mucosa with water contaminated from excreta of an infected animal like rat and dog. This is majority in India, spread at the eastern India, western India, and the southern part of India. Increasing incidence in non-endemic, that is northern India, is also being reported nowadays. Mainly, this organism involves the small blood vessel endothelium, resulting in the damage and fibrosis. So these are the symptoms one can look upon in the case of leptospira. These are red eye, abdominal pain, chills, rashes, and in icteric phase, yellow skin or eyes suggestive of a jaundice. So clinical features are generally divided into two phases, which is called biphasic clinical presentation. First is a unicteric leptospirosis, wherein the patient present with the general symptoms of fever, chills, headache, myalgia, abdominal pain, and transient skin rash. If not diagnosed and treated on a time, 5 to 15% of patient can get complication of a jaundice, proteinuria, pulmonary hemorrhages, ARDS, and myocarditis. So one can advise these tests for a diagnosis of leptospira infection. Lateral flow immunochromatography is the rapid test available, which is 87% sensitive and 70% specific. Leptospira IgG and IgM ELISA are the best and confirmatory method for diagnosis of leptospira with 88% of sensitivity at max and 90% of specificity at max. Microscopic agglutination test is a special test and have the maximum sensitivity of 96% and specificity more than 98%. PCR is also available, which has the specificity of 82%. The next most important and common prevalent monsoon fever is a dengue fever, which is caused by flavivirus from a 4 serotype 1 to 4. The vector responsible for dengue fever is Aedes mosquito. Dengue is endemic throughout the India with recent resurgence of epidemics over the past 2 decades. The pathogenesis mostly involve the endothelial function, platelet destruction, and consumption of coagulation factor. In case of secondary dengue infection, when patient get infected with a different serotype from the primary one, the immune system will over-respond and cause a cytokine storm, which eventually will lead to the multi-organ dysfunction. The clinical feature will be categorized depending upon the severity as a dengue hemorrhagic fever, wherein the platelet count will be lower than 1 lakh and which cause the skin, mucosal, and gastrointestinal bleed. Dengue shock syndrome, the patient present with hypotension, pulse pressure more less than 20 mm of Hg, and weak pulse. In expanded dengue syndrome, which are nothing but the complication of dengue fever if not diagnosed and treated appropriately, are encephalitis, myocarditis, hepatitis. To advise an appropriate test for diagnosis of dengue fever, one has to be aware of the appearance or timeline of the appearance of the dengue antibody. During the initial 5 days of the dengue fever, there will be a viremic phase wherein one can advise the NAT test, which is nothing but a PCR test, and NS1 antigen detection by ELISA or rapid test. At the end of these acute infection, IgM antibody appear in 50% of patient by 3 to 5 days of the onset. During secondary dengue infection, IgG level will be high in the acute phase itself, and the NS1 antigen and IgM antibody will be detected in the early phases too. For the diagnosis approach, one can be available with these investigation set. The most common routine advised test are the rapid test followed by MAC ELISA, which is the most confirmatory method with a 90% of sensitivity and 98% of the specificity. RT-PCR are also available with a 90% of sensitivity at max and 100% of specificity. RT-PCR also help us to differentiate the serotype circulating in that particular geographical area. Coming to the next most important prevalent monsoon fever is the malarial fever, which is caused by the Plasmodium protozoa. There are different species of Plasmodium protozoa, which are falciparum, vivax, and malaria predominantly. The vector responsible for the spread of the malaria is Anopheles mosquito. The Plasmodium species are currently unevenly distributed in India. Most affected part are Orissa, Chhattisgarh, West Bengal, Jharkhand, and Karnataka. Malarial parasite mostly involve and the reticular endothelial system, wherein by cytoadherence to the vascular endothelium, parasitis RBC and sequestration of intravascular hemolysis occurs. The clinical feature shows paroxysms of fever, wherein there will be a typical spike of a fever depending upon the infecting species. For example, in falciparum species, one can see the rise in the fever spike alternate day. In case of Vivax, one can see the spike of a fever at every third day and fourth day in case of malaria and ovary. In majority of cases of malaria, hepatosplenomegaly will be there. In case of a complicated malarial cases as cerebral malaria, patient may present with coma and acute renal failure with creatinine more than 3 milligram per dl. One can avail the battery of tests for the diagnosis of malaria are as below, as shown in the table. The most specific and sensitive test is a microscopic blood examination, wherein 100% specificity will be there, and as low as 10 to 20 parasite per microliter of blood can be seen in the thick blood film. Rapid tests are also available for malaria, which has the sensitivity of 94% and specificity of 75%. Coming to the next important prevalent monsoon fever is the enteric fever. Nowadays, in this monsoon fever, we are more of encountering these enteric fever. So this is caused by Salmonella typhi, paratyphi A and B. This is transmitted by fecal-oral route and have high incidence in children 15 years of age and younger. It involves the reticuloendothelial system in area of a greatest macrophage concentration, such as Peyer's passage, which are predominant in the intestine. The patient can present with the general symptoms like fever, headache, relative bradycardia, followed by abdominal pain, diarrhea, or constipation, along with the hepatomegaly and encephalopathy in second week. If not treated on time and diagnosed on time, this may turn into the complication wherein one can see the intestinal bleeding, perforation, multi-organ dysfunction. So these are the typhoid symptoms one has to be aware and think of a typhoid. The diagnostic modality available for the typhoid fever are majority people prescribe the Vidal test, which has the sensitivity of 88% and specificity of 80%. But in case of a typhoid, one should be aware of the endemic titer of their geographical area. One has to test for pair sera to see the rising titer, which is a significant finding. One has to think of also the vaccination for typhoid. One has to rule out the amnestic reaction for the Vidal test to interpret properly, which is for few people are even prescribing IgM detection against Salmonella typhi, which is a rapid test, which has the sensitivity of 50% and specificity of 100%. Culture of a blood and bone marrow are the most confirmatory tests, wherein the bone marrow culture show the sensitivity of even 90% and blood culture sensitivity of 50 to 70% if the blood was withdrawn at the time of a fever spike. Even stool culture can be done, but it has this sensitivity of only 30 to 40%. PCR is also available with a high specificity of 100% and sensitivity of 80%. Coming to the next important prevalent monsoon fever, which is chikungunya, which is caused by the family of virus Togaviridae. This is caused by the same vector as of dengue, which is Aedes albopictus. So one can get infected from both chikungunya and dengue at a time. So co-infection are high in the area where this mosquito prevalence. So the patient present with mostly in case of chikungunya with a crippling joint pain, fever, myalgia, nausea, and vomiting. One can avail these array of diagnostic tests wherein one can prescribe rapid diagnostic test, that is a lateral flow immunochromatography with the sensitivity of 100% and specificity of 95%. Maculaza is the most advisable and preferred test with sensitivity of 100% and specificity almost more than 99%. Coming to the next prevalent monsoon fever, hepatitis A, which causes diarrhea and caused by the virus from Picorona family. The transmission is by fecal-oral route, and the most advisable test for hepatitis A is HIV IgM ELISA, and even we can do the CMI method, wherein the sensitivity will be 100% with a specificity of 99%. Another diarrheal disease caused by the hepatitis E virus is also important, which is mostly fatal in the pregnant woman caused by Hepatitis family virus. The transmission is also from fecal-oral route. The most important diagnostic test is the HIV IgM for alpha and by alpha and ELISA. Alpha has the sensitivity of 91% at max and specificity of 100%. PCR can also be done for the HIV virus, wherein the sensitivity for PCR is 100% and specificity is the 100% too. Last but not least, the amoebiasis, which are the diarrhea, which cause the diarrhea caused by Entamoeba histolytica. The transmission is by fecal-oral route. These are the different diagnostic tests one can offer. The most important is the abscess antigen detection and antigen detection in a stool, which has the sensitivity at max more than 100% and the specificity of more than 95%. The amoebia cause the extraintestinal syndrome also. Coming to the viral influenza like illnesses, post COVID, all are aware of these viral influenza like illnesses, which are mostly caused by adenovirus, influenza family viruses, then human metapneumoviruses, parainfluenza virus, etc. The clinical feature are general symptoms such as high grade fever, cough, sore throat, myalgia. The patient should be warned about the symptoms, as if not diagnosed and not reported on time, it may turn fatal. The diagnostic array for viral influenza are very limited, so that one has to exclude by the ruling out the bacteriological etiology, probably by basic investigation. But now we are available with a few specific viral infection diagnosis through the PCR and heme agglutination method, even by serology, by finding out the antibody to those specific viruses. So we are now available with PCR, for example, express flu, which is nothing but done by the nested real-time PCR done in the gene expert instrument, wherein we can able to diagnose and differentiate influenza A, B, RSV, and SARS-CoV-2 also. So, looking on to the syndromic approach for its diagnosis and to start empirical management, we have compiled few basic investigation with a specific investigation as a fever profile and a capsule, wherein we have made sure that few basic investigation are there which help us to differentiate for a specific diagnosis. The more important thing is prevention is better than cure. Though we are doing the diagnosis on time, though we are treating patient on time by making sure that we are doing basic investigation thing, but prevention is always the first and most important thing we need to look upon. In the monsoon season, prevention, as post COVID, we are all aware about these prevention things, and we are more aware of infection control practices, wherein one has to take care of their healthy lifestyle and has to make sure in these rainy season to protect themselves from the vector like mosquito bite, wherein we can get rid from them by using repellent and protecting ourselves by a full clothing. One has to wear also shoes wherein leptospira can be transmitted by water through the rat and dog excreta, so we can utilize these precautionary methods. So to conclude, though prevention is the best thing, but if someone comes to the OPD to the physician with these fever spikes, one has to advise the basic investigation, which will help us to reach a differential diagnosis for specific diseases. In specific investigation, one can advise serological test or microbiological test. In sick patient, the idea is to hit the wide and hit early with the intention to de-escalate once the definitive diagnosis is established. So this is all about our monsoon fever and their diagnosis in short. So thanks for your patience listening. Now I'll hand over to Dr. Manisha. Dr. Manisha, madam, please.
Thank you, Lata, for such a informative presentations. So I think so you'll agree with me that monsoon fever can be divided into vector-borne and fecal-oral-borne. So to
Yeah.
prevent also, we have to conclude that vector-borne, we can, as you said, we can prevent us ourselves by using the mosquito repellents and mosquito nets and all those things. Fecal-oral, hand washing. After COVID, everybody has got into a very good practice of doing hand washing regularly. So that should lead into decrease of the fecal-oral borne diseases. So just to summarize, do agree with me. If I'm wrong, please correct me. Dengue and chikungunya, same mosquito. So suppose we follow the same precaution, we will be safe. And when the patient presents to us dengue and chikungunya, both diseases near about look similar. There won't be much difference, at least in the start of the fever. So best is to check for both dengue and chikungunya at a time when the person is presenting with high grade fever and having muscle pain and joint pains. Hepatitis, fecal borne hepatitis, we have already started seeing a rise in cases of HIV IgM positive cases as well as HIV IgM cases, even though monsoon has started just a week ago. So the fever oral cases are on rise. Enteric fever, I just would like to say that enteric fever, we do vital test. But if the fever is very recent, within 1 week of fever, vital test is known to come negative. So if the person is in first week of fever or fever is only for some 3 4 days, then best is to advise for blood culture. Only if the person's fever goes beyond 7 days, then we can go for the vital test. So as you said, a paired sera would be best, but unfortunately, we never get a paired sera. We get a sera which is there only in the first week, and then the person is like, okay, lymphocytosis is there, what should we do? And then, so if it's in the first week, best is blood culture rather than the vital test. I think so. Malaria, we everybody knows what it is, but still we have not been able to control it, and we are still facing a lot of challenge due to the mosquito-borne diseases. So the monsoon season, the best way to prevent ourselves is to prevent from the mosquito bite and not eating out. Probably will help us a lot in preventing all the mosquito-borne diseases. Thank you. Uh, I think so. There are no queries. Anything else you want to add, Dr. Lata?
That's all, madam. As you truly said, though we have a different diagnostic approaches which are newly coming up, but the prevention is the best method. The COVID epidemic, pandemic has taught us about these all infection control practices which we used to ignore before. But this COVID pandemic has really taught us that prevention is better than anything. And now the techniques are so well, even the patient get infected, we are available with the different kind of PCR, even the different kind of serological test which help us to diagnose early. So one has to remember, whenever you have a fever, don't ignore it, report early to your physician, because these monsoon fever though look very normal, if not treated and diagnosed on timely, may turn fatal. As nowadays you can see, if dengue fever is not getting treated on time, though the treatment is very simple, it's just a maintaining hydration and just following it with a platelet count. But one has to find out that one can't ignore just saying that it's just a normal viral fever. But though even viral fever will turn in the complication in old ages or comorbid condition like ARDS, sometimes encephalitis also. So the most important thing is to be aware and report to your physician as early as you see a rise in a fever of something abnormal symptoms are also associated with the fever. That's all.
So thank you, everybody. Thank you, Lata.
Thank you.